Hello, welcome everyone to the PrecisCa Lung Cancer Tumor Board. I want to welcome all our panelists today. I am Ramaswamy Govindan, a medical oncologist at Washington University in St. Louis. I'm joined today by our experts. We'll start out with the introductions. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center and Professor of Radiology at Weill Cornell Medical College.
I'm Larry Keston. I'm a radiation oncologist in the Detroit, Michigan area for Michigan Healthcare Professionals and Genesis Care USA Medical Director in Michigan.
I'm Tom Stinchcomb. I'm a medical oncologist who specializes in thoracic oncology at Duke University in Durham, North Carolina.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
A 63-year-old woman, predictably a never smoker, who presented with increasing back pain and a performance status of 2 because of the back pain, had a history of hypertension, pneumonia, and as I said, no history of tobacco smoking. And in January of 2021, had a mass in the lumbar spine with metastasis and got metastasis. Also had, unfortunately, multiple brain metastasis. Had surgical resection of the lumbar lesion, and biopsy was consistent with adenocarcinoma, and the mutation testing revealed exon 19 EGFR mutation. And she underwent radiation therapy to the brain as well as spine. And we have the CT scan from the diagnosis. Dr. Ginsberg?
Well, in this image, we see that we have bilateral, patchy, ground glass opacities, more in a peripheral distribution, a few small areas of consolidation. All these are very non-specific findings, but in the appropriate clinical setting could represent a pneumonitis, which could be treatment related.
So this is, I think you are right on, and this patient initiated osimertinib, and within a month became quite symptomatic with hypoxia. And would you say that these findings are quite consistent with drug-induced pneumonitis in this setting?
In the appropriate clinical setting, yes. That's what we would suggest.
And, one thing to have asymptomatic or minimally symptomatic pneumonitis, another thing is to be, to have significant pneumonitis requiring support in the hospital. The challenge here is a tumor that is amenable to traumatic responses with osimertinib and EGFR TK inhibitor, but unfortunately the pneumonitis is pretty severe. Again, a common problem, Dr. Stinchcomb. How would you manage this patient?
Thank you, Dr. Govindan. I think that this is one of the more challenging scenarios because you have a tumor that's very sensitive to these medications, but this patient has experienced a relatively severe toxicity. I think there are case reports of re-challenge of osimertinib, but I really can't say that that's a standard of care option at this point because I think there are only case reports, and also in this case specifically the severity of the toxicity. Therefore, the standard therapies would be either a platinum doublet such as carboplatin and pemetrexed, and then I think the 4-drug combination of carboplatin, paclitaxel, atezolizumab, and bevacizumab has shown activity in patients with EGFR mutation who've had progression on a tyrosine kinase inhibitor, albeit a subset analysis of a larger trial. And so I think those would be sort of the 3 options that I would discuss with this patient.
This is a common problem, and this is a common scenario where we, lung cancer experts, get called for assistance. The one question I get frequently from our community oncology colleagues is that, how about trying erlotinib? Would you do that?
Personally, I would not. I think that there's a rate of pneumonitis with all these drugs, and I think my concern is the rate of pneumonitis may be the same with erlotinib, but the efficacy may be less, and so therefore, I'm a little bit concerned that changing the class of drug from a 3rd generation to the 1st generation is going to reduce the risk of recurrent pneumonitis.
Yeah, I agree with you. In fact, this is a class effect, not a drug-specific effect. And in general, my rule of thumb is that if somebody had, occasional cough and very faint infiltrates, we would consider treating them. But then if somebody required oxygen, had to be in the hospital, that too within a month, of starting this. Switching to another EGFR TKI inhibitor would not be a good idea. And I think osimertinib or any other EGFR TKI would very likely result in significant pneumonitis. And in the early days, I've lost a few patients in the past from EGFR TKI-induced pneumonitis. So this is not a trivial issue. The other challenging question is that with somebody who has experienced pneumonitis, is it reasonable to give them a checkpoint inhibitor like pembrolizumab or tislelizumab, the way you mentioned? Would you just give this patient just a doublet therapy, or would you venture to add an immune checkpoint inhibitor alone or with, as you said, bevacizumab?
Complicated question. I think there's some concern that the sequencing of immunotherapy and TKIs, there might be a higher rate of pneumonitis for osimertinib after immunotherapy, and there's some interaction. I personally found the 4-drug Empower regimen to be relatively difficult to give, largely due to the taxane toxicities. And in this patient who's PS2, if I recall correctly, I would probably lean a little bit more towards the carboplatin and pemetrexed, really for multiple reasons at this point.
I agree with you. I would treat this patient with pemetrexed and carboplatin because, as you and I know, pemetrexed is quite active in this population. Patients tolerate this drug very well with no neuropathy. And although you have to watch for fatigue, some nausea, fluid retention, and some renal dysfunction, especially if they take other agents like non-steroidals. But by and large, it's well tolerated. I try to stay away from immune checkpoint inhibitor for these patients right after the EGFR TKI inhibitors. And I also do the reverse too. I'm very cautious in starting somebody with locally advanced non-small cell lung cancer with EGFR mutation who will receive durvalumab. When they progress, I don't start them right away on osimertinib. I do give them some time to cool off for the effects of them to go away, at least 3 months. And there is some concern that concurrent checkpoint inhibitor and EGFR TKI, certainly not a good idea. It leads to higher incidence of pneumonitis, upwards of close to even 25%. But even sequential one, I've seen anecdotally people running into problems. So I would stay away from checkpoint inhibitor in this situation. And I almost never use the 4-drug combination. I don't see a big advantage with that. And you led Dr. Stinchcomb studies that really looked at the benefit of adding bevacizumab. So since you said you won't give checkpoint inhibitor, you would give pemetrexed carboplatin, would you add bevacizumab in this setting? And you led one of those seminal trials here. So do you want to comment on that?
Sure. I think, thank you for Dr. Govindan. I think there are trials of EGFR TKI plus bevacizumab, and I think in most trials, the response rate was the same, and there might be a difference in progression-free survival, but not overall survival. And I think we're the EGFR mutation subtype may get a little bit more benefit from bevacizumab than the general population, but I'm not convinced that it's such a great benefit to add the additional toxicities that we see with high blood pressure, coughing up blood, hemoptysis, and hypertension at this point. And I most often have done carboplatin and pemetrexed without bevacizumab in this situation.
Yeah, and in terms of the future directions, so there are other, the dual antibodies, the EGFR MET antibody that just got approved for the exon 20 EGFR insertions, EGFR exon 20 insertion, I should say. And but I still think the class effect would be an issue, don't you think?
I think so, and I think it's a very difficult when the patients get this toxicity, because it does sort of really limit your options down the road. So when I have patients, I make sure that we really have done due diligence to exclude everything else. And I worry sometimes now with immune therapy and TKIs, people are so reflexively putting on prednisone and calling it pneumonitis and not realizing the long-term implications.
I want to bring one practical point here, and I want to bring Dr. Ginsberg into the discussion now. When I see patients who have had drug-induced pneumonitis, osimertinib-induced pneumonitis, I have a patient exactly like this, a physician's mother who had significant pneumonitis, exactly this description, and we weaned her off. We obviously took her off prednisone, or took her off osimertinib, put her on prednisone, and weaned her off prednisone. And now what we see is, now and then we see this interstitial infiltrates get a little dense, and then the radiologists read this as consistent with disease progression, although symptomatically this patient is remarkably better. while a good portion of the lung is cleared, over time, we do see some changes, and there's always this concern: is there an underlying lymphangitic disease progression, or disease, or this inflammation acting up? Any comment on that?
I mean, more commonly in my experience, these things either go down and resolve or leave some residual interstitial thickening, more like a fibrosis. It's rare that you would have lymphangitic spread, and it wouldn't be in both lungs anyway. So if you see it bilaterally, I would favor some residual of the pneumonitis. And it's interesting when you said that erlotinib in the early days, we saw a fair amount of pneumonitis and more severe in some sense than what we're seeing now with osimertinib and other drugs.
It's also that we've learned how to watch for them and prevent them from getting worse. And I'm sure there is a learning curve there too. So
Right.
I think this is a great discussion. So I want to summarize that. How do you manage somebody with EGFR pneumonitis? And I would say that the main issues with the EGFR pneumonitis is obviously to stop osimertinib and then treat these patients with appropriately prednisone. And once the symptoms have gotten better, these patients are treated mainly with chemotherapy. And the recommendation of the tumor board is to hold off on using immune checkpoint inhibitor or VEGF inhibitors and use predominantly platinum-based chemotherapy for these patients. The tumor board also would recommend that patients who have had the osimertinib pneumonitis not be treated with other EGFR TK inhibitors, as there is a concern that this is a class effect, and that would be applicable for the newer emerging EGFR antibodies as well. Thank you very much.